All right, let's get this started. Woo. Welcome to the 2021 Virtual Liver Expo hosted by UCSF Fresno and your program director, Dr. Marina Roytman. More about her in a moment. Thank you so much for joining us today on this Saturday. We're glad you could take time on this day, this smoky, hazy day. I mean, I want to be back in person, but I'm kind of glad I'm out of this smoke right now. So, pros and cons. But we're glad you could be here today to join us for the Liver Expo. This is the third year we're doing this program. I mean, the second virtual, but I swear it's the third time we've done it. We've done it once in person. We'll be back in person again next year if all goes well. So thank you so much for joining us. First, I want to start by just asking where you're joining us from. So chime into the chat. Let us know. Just tell us the city you're attending from. We would love to see it. It makes me so excited to see where everyone's coming from. And it gives us, let's work on the chat. Let's see how we can use the chat. Reedley, Clovis, Fresno, Bakersfield. All right, lots of Valley representation. Alamo, good morning. From Merced, lots from Fresno, Dinuba. Wonderful. Lots of Fresno. Honolulu, there we go. I was hoping we would have someone from out of California. Welcome, Deanne. I know it's early for you, so thank you for being here. Wonderful. Tennessee, woo! This is great. Well, thank you everyone from wherever you're joining us. We appreciate you being here. So just a few little bits and pieces of housekeeping information. If you want to check out our virtual vendor hall and put your name into the raffle, we have some great prizes. We're giving away a $50 Sprouts gift card, or we'll do something equivalent if it's someone from Tennessee or Hawaii. We're going to do a home gym set, which is really cool, and then a really neat kind of nutrition book. So some good prizes. Hopefully you'll go to that page. I put it in the chat. You can go ahead and check that out when you have a chance. And then during the presentations, if you have questions, go ahead and chime into the Q&A and put your questions there. We will get to them at the end of each session. So now let's talk about your program director. Okay, Dr. Marina Roytman. Dr. Roytman joined the University of California, San Francisco, Fresno in August of 2017 as a clinical professor of medicine for the Department of Internal Medicine, and she is the director of the liver program in the Division of Gastroenterology, Hepatology, and Nutrition. Dr. Roytman's involvement in research encompasses areas in hepatitis B, hepatitis C, drug-induced liver injury, non-alcoholic steatohepatitis, cirrhosis, and liver fibrosis. She loves teaching hepatology to all levels of learners, from patients to providers. Please welcome Dr. Marina Roytman.
Summer, thank you so much for this kind introduction. And thank you everybody for joining us again virtually. As Summer says, we can't wait to see you all in person and go back to the our boot camp and our cooking demonstration and all our tests that we can do in person. So hang tight, we're gonna be back next year. So today I am going to talk about the health of the liver, or as my sign says, is your liver well? And there's gonna be a twist to it. We're gonna talk about the health of your liver during the pandemic. I'm gonna go ahead and share my screen. Okay, we're good? All right, very good. So is your liver well during the COVID-19 pandemic? Well, if I'm talking about it, you might infer that certain things have not been going really well with our livers. So we're going to talk today about a few things that we've talked about before. What does your liver do? What are the things that can damage the liver? We will focus a little bit on fatty liver disease, hepatitis C, and the new and very relevant topic is alcohol-related liver disease. We'll review how one can find out if they have liver damage and what we can do to improve the health of our liver. So first of all, where is my liver? So the liver is hidden under the right rib cage over here. And the healthy liver is completely hidden under the rib cage and cannot be felt. It's about the size of the football, roughly. What does the liver do? Well, the liver has two main functions. The first function is the liver is the body's factory. It makes protein that helps our blood clot, and it also makes protein to helps our bodies to be nourished. The second thing that the body does, along with the kidneys, it removes toxic substances from your body. So two very important functions. So what happens if the liver is damaged, right? So the first thing that happens is, like any organ, liver initially will become swollen. It may be felt below the ribs when the doctor is examining you. More serious or ongoing damage will lead to liver scarring and liver becoming small and hard. This is called cirrhosis. Cirrhosis means a lot of liver scarring. So this is what a normal liver looks like. This is what a cirrhotic liver looks like, lots of scarring. And what I want to point out, while alcohol is still the leading cause of liver cirrhosis, there are lots and lots of other things that cause liver damage in the non-drinkers. What are the physical signs of liver disease? When should we worry? So the first and probably the most well-known one is yellowing of the eyes or the skin, okay? Patients with advanced liver disease lose muscle mass. You can see that the gentleman over here, not only he's skinny all over his body, but you can see the loss of tissue on his temple and around his cheeks. These things are often seen on the skin, on the chest or the shoulders, and they're called spider angiomas. These are the signs of advanced liver disease on the skin. Nails also can tell us about advanced liver disease. You can see how the nails kind of curve forward, and this is called nail clubbing. You can see breast enlargement or gynecomastia in a man, and this is because the liver isn't able to get rid of the extra estrogens that it produces, that our bodies produce. This is abnormal veins on the abdominal wall. This is called caput medusa. We already talked about liver sticking out from under the rib cage. Spleen, which is intimately connected to the liver, can also get enlarged. This is called ascites, and this enlargement of the abdomen is called by abnormal accumulation of the fluid in the abdominal cavity if the liver isn't working right. So what can damage our liver? Alcohol is the #1 cause of liver damage. Viral hepatitis or infection of the liver is a very common cause of liver damage. From Latin, hepa means liver, itis means inflammation. There are several types of viral hepatitis. It's A, B, C, D, and E. And we're going to talk a little bit about the C today. And the last common thing is excess weight. Excess weight may lead to liver damage similar to viral hepatitis or alcohol misuse. So first we'll talk about non-alcoholic fatty liver disease. So what is with all this alphabet soup? I'll help you understand it. So NAFLD is non-alcoholic fatty liver disease, is an umbrella term, okay? That means fat in the liver without a good alternative explanation. And a good alternative explanation would be drinking too much alcohol. So non-alcoholic fatty liver disease happens in patients who do not drink alcohol excessively. Now, under this umbrella term, we have two things. One is NAFL, non-alcoholic fatty liver disease. It means that there's fat in the liver, but it is not causing significant problems. NASH is the feared complication of NAFLD, and this is when fat in the liver is causing inflammation and eventually scarring. After all these years, I'm finally comfortable in my own skin, maybe because my skin is a lot bigger than it used to be. Well, indeed, this is the case. This is an American epidemic. 1 in 3 Americans likely has a fatty liver. Ultrasound data estimates that as many as half of the Americans may have fatty liver. The diabetics it's very prevalent in diabetics. Up to 90% of patients undergoing weight loss surgery. And it's significantly more prevalent in patients than hepatitis C. However, we don't talk anywhere as much about fatty liver. So this is the maps that you've seen before, right? So we're looking from the mid-90s to 2015. You can see the increase in obesity, which is paralleled by increase in diabetes. So let's look a little bit more carefully on this map. So 2015, the darkest red indicates prevalence of obesity of greater than 26%. Now let's fast forward into the COVID pandemic. So this is 2020 prevalence of obesity among US adults, right? So let's look at the colors, right? So we can see kind of the orangey color and a darker red color. The orangey color starts at 30%. So we're no longer at 26% where we are in 2015. We are starting with the majority of the country being at 30 to 35% of obese adults, moving into the 35 to 40% adults. It gets worse. In a Hispanic population, we are primarily looking at the darker red, which is 35 to 40% obesity rates. And we even have areas of dark red, which is greater than 40% obesity, which is really frightening statistics. It still gets worse. When we're looking at non-Hispanic Black adults, we are solidly more than half of the country at greater than 40% obesity. So non-surprisingly that the fatty liver disease is a actual pandemic in America. What about the children? What happened to the kids during the COVID-19 pandemic? They didn't go to school. They didn't play sports. They spend 8 hours a day on Zoom and even more later on. So what happened to them? Well, unsurprisingly, there was stark increases in obesity. So this is a study that looked at almost 500,000 children ages 2 to 18. The rate of BMI or body mass increase doubled during the pandemic. Children who were overweight or obese before, as well as the younger school children, 6 to 11 years old, experienced the largest increases. So let's talk about who's at risk for fatty liver disease. Well, the key word here is people with metabolic syndrome. Metabolic syndrome includes diabetes, high blood pressure, high cholesterol, and excess fat around the waistline. This is called central obesity, and this is the type of obesity that is associated with heart disease, with fatty liver disease, and other health complications. So what exactly happens in fatty liver disease? So these are biopsy examples of fatty liver disease. So over here on the first slide, we see just fatty liver. Those white circles are literally globs of fat in the liver. As we move on, you can see we still see the white globs of fat in the liver, and we're starting to see those blue dots. Those blue dots are inflammatory cells. This is what gives us the inflammation. This is what causes your liver test to rise. As time goes on and we don't do anything about it, we start seeing scarring. So the blue lines are the scars in the liver. As we move further, we can see that over here, most of the liver now is taken out by the blue lines or the scars. This is called cirrhosis. And the most feared complications of fatty liver disease is development of liver cancer or hepatocellular carcinoma. In the past, we believed that you had to go through this whole continuum from fatty liver all the way to cirrhosis before we had to worry about liver cancer or hepatocellular carcinoma. Now we understand that even patients who have not gotten to cirrhosis but have inflammation in the liver due to fatty liver are at risk for liver cancer and should be screened for it. So who's at the greatest risk of complications of fatty liver disease? Is it the people who have fat? Is it the people who have inflammation? Or is it the people who have the scarring? So what this study shows us that it is the scarring that is the problem. People who have more advanced scarring, fibrosis stage 3 or 4, have a significant impact of their length of life compared to the people who do not have significant scarring. So it's all about the scarring, and we'll talk later in the presentation about what causes the scarring or how to find out if you have the scarring. Now, the handle on your recliner does not qualify as an exercise machine. Well, the good news is that regular exercise works. We had over 300 patients in the study who were observed for 52 weeks, and they were recommended to adopt lifestyle changes to reduce their weight. Most of the patients had biopsies before and at the end of study. And about 30% of patients lost greater than 5% of their total body weight, which just kind of mirrors the real life experience. So what happened is, and I want you to pay attention to just this last column. I want you to pay attention to the people who lost greater than 10% of their body weight. 10% is not a lot. If a patient is 200 pounds, it's 20 pounds. It's doable, right? But 81% of patients who lost greater than 10% of their body weight saw reversal in liver scarring, right? We used to think that scarring was irreversible, but now we understand it's very much reversible with some weight loss and lifestyle modifications. So this is great. Everyone knows that food is bad for you, but I don't know what else to eat. What can I eat? So a few things. So first of all, food that is not processed, right? And later on in the conversation, we will hear from our nutritionist a lot more about it. But basically, if it comes in a package and if there's stuff on the package that you don't know what that means, do not eat it. Also, eat the food that your grandmother would eat, right? Our grandparents, at least my grandparents, were eating still a pretty healthy and natural diet. Now, in addition to lifestyle modifications, which is exercise, healthier eating, there's a couple add-ons, right? They do not fix your fatty liver, but they are add-ons to your program. One is coffee, two is yogurt. Both of those foods lead to the healthier gut bacteria. The healthier gut bacteria in turn decreases inflammation in the liver. And as we remember, inflammation is what leads to the scarring, right? So, but we do not want to dump tons of cream and sugar in our coffee, and we do not want to buy sweetened yogurt because this is just like eating dessert. We do not want to use probiotics in pill form because this violates our number one rule. These are processed and we don't know what's in them. Right now, I cannot give you a pill for fatty liver, right? There are lots and lots of work that is going on to come up with a pill for fatty liver. However, it's a very complex process, right? There's lots of things that involve. There's behavior, there's access to healthy food and exercise. So lots of things. So we are, I hope that in the next few years, we will have some medications for fatty liver disease, but they will always will need to be paired with lifestyle modifications. So there's a few names that some of you may be familiar. Some of you may have participated in these studies. And unfortunately, so far, none of these studies came with positive results. None were harmful to the patients, which is great, but they did not lead to the positive results in terms of reversing fatty liver disease and the fibrosis from it. The good news, we have lots more studies that we are currently looking at, different approaches that hopefully will result in some benefit in patients with fatty liver disease. Do we have clinical trials in Fresno and can I participate? Yes, absolutely, emphatically, yes, we are back after a long interruption from COVID. And if you are interested, please contact Sonia Garcia, our clinical research coordinator. Now we're going to switch gears and talk about what else can damage my liver. Well, alcohol, unsurprisingly. So how much alcohol is in a drink, right? So when we look at beer, if you drink a can of beer, it equals to 1 drink. If you drink a pint of beer, it's actually 1.5 drinks. So 2 pints, 3 drinks, right? Moving to the wine, so 1 small glass equals 1 drink. It does not mean 1 small glass is like how it used to be 20 years ago in a restaurant, not the big glasses that we serve now. And 1 bottle is 5 drinks. That's a whole lot of drinks. Now, where we really get into trouble is with the distilled spirits, right? Vodka, tequila, whiskey, whatnot, right? 1 shot, which is 1.5 fluid ounces, very little, is 1 drink, right? 1 pint is 8.5 drinks. 1/5 is 17 drinks. And I have to tell you, there are a lot of patients that I see that are in the pint and a fifth of hard liquor category. How much alcohol is safe? Well, we kind of used to think that light to moderate intake reduced the risk of coronary artery disease. Well, this is kind of really being disputed right now. It may or may not be true. We do know, however, that heavy chronic alcohol intake increases risk of heart failure, blood pressure, abnormal heart rhythms, as well as hemorrhagic stroke. It is also established that alcohol is carcinogen. It causes cancer, and there's no safe threshold established. Obviously, it causes cirrhosis. We should know that stopping drinking at any point reduces risk of disease progression and recurrence of complications. So having said that, drinking in moderation means 1 drink or less for a woman and 2 drink or less for a man. So what happens if I drink excessively? Well, one thing that can happen is liver cirrhosis. As we know, liver cirrhosis is severe scarring of the liver. It takes years of heavy drinking to get there. It can improve with abstinence. And after a period of abstinence, which is usually 6 months, if you're not recovering, we can consider liver transplantation. Alcoholic hepatitis is something you may or may not have heard of, but it's a big problem right now. Alcoholic hepatitis is a severe inflammation of the liver. It happens fast. It can happen in as little as a weekend of a binge drinking or as long as weeks of heavy drinking. It can happen really quickly. It can improve with abstinence. It can also progressively get worse and lead to liver failure. The issue of transplant is complicated because patients with alcoholic hepatitis often have been drinking right until they come to my attention or right up until they got admitted to the hospital. So it is challenging to get these patients to qualify for a liver transplantation. Also, this population is very young, and it can be heartbreaking if we're not able to help them. What are the symptoms of alcoholic hepatitis? Can be very subtle. It can be fatigue, you're not really hungry, there's maybe some nausea, vomiting, some stomach upset, you may or may not have a low-grade fever. Eventually, you or your family may start noticing that your skin or eyes are turning yellow, and as you get sicker, they're going to be swelling of abdomen and your legs. So what happened in Fresno during COVID-19 pandemic? So this is a study that is about to be published, and I'm sharing that with you kind of hot off the press. So what we're looking at here is in the blue lines is the rates of alcoholic hepatitis that were severe enough to require hospital admission in 2019. So you can see the blue bars, nothing exciting happens. The orange bars is during COVID-19 pandemic, and you can see the dramatic increase, 51% overall increase. 69% increase in stay-at-home orders. So really dramatic numbers. It gets, when we look more into the data, there has been 125% increase in women, unsurprisingly, with how much fell onto women's plate during the COVID-19 pandemic. We had a dramatic increase, 100% increase in younger patients, again, unsurprisingly, with all the stressors that were loaded on the younger people. So these were really dramatic changes, which we saw in our clinical practice, which prompted us to do this study. So why did this happen? Lots of reasons, right? Many states relaxed alcohol laws. When we look at the early pandemic timeline, there was a 54% in alcohol sales in stores and almost 300% of increase in alcohol sales online. So we had increased stress, we had availability, we had boredom. All of those factors led to this pandemic within a pandemic. The treatment for alcoholic hepatitis is abstinence. So stopping drinking immediately is the best thing that we can do. Unfortunately, there's no medications that can reliably cure the effects of liver damage. The best that we can do is to stop drinking. Fortunately, Alcoholics Anonymous pivoted early in the pandemic to offer online services to the patients in need. So that was a great resource. They're still continuing to do it. And if you or your loved ones need help, please turn them to this resource. Moving on, what else can damage my liver? Hepatitis C, we've talked about this before. Hepatitis C is a viral infection of the liver, right? It takes a long time to get there. It can be 10, 20, 30 years to get from a healthy liver to a cirrhotic liver. Patients have very few symptoms and often do not seek care. The problem in the United States is that we have lots of people with the virus, close to 3 million. Few are aware, about 500,000. Fewer are treated, but the good news in those who are treated, almost everybody has been cured. Now, why is hepatitis C curable? Why can't we cure AIDS or other, or hepatitis B, for example? Well, we just got really lucky with hepatitis C. The viral material or the viral RNA of hepatitis C hangs out outside of the nucleus in the cell. So the drugs can come in and easily get it, unlike like in hepatitis B or HIV, where the viral material lives inside the nucleus and the drugs have a harder time getting it. So a few years ago, we thought that most patients who had hepatitis C belonged to the baby boomer generation, 1945 to 1965 date of birth. However, fast forward to 2015, we can see that this drastically changes, and we're seeing the majority of the patients in the younger 20 to 30 groups. So what we're seeing here, that among people aged 18 to 29, we have a 400% increase in HCV cases. Among the patients in their 30s, there's 325 increase. All of this is attributed to the opioid epidemic. Certainly, opioid epidemic has not improved during the COVID-19 pandemic. Fortunately, is CDC during the COVID-19 pandemic 2020 made this awesome update. It said that instead of focusing on the baby boomers, or instead of focusing on patients who are at high risk, like drug users or whatnot, let's just screen everybody. Everybody who's 18 years older, we're just going to go ahead and screen you, just like we screen you for diabetes or high cholesterol. So this is a great development. All patients who are pregnant should be screened for hepatitis C each time that they're pregnant. And this is a great recommendation too, because if we're talking about younger people, right, these are the people in their prime reproductive years, and this is when they are in care. Now, COVID-19 pandemic has not helped us to manage the hepatitis C situation. You can see that in red, there's a drastic decline in hepatitis C testing, which is attributed to pandemic. So we're hoping that we can bounce back quickly and get back on board with diagnosing and treating our younger patients with chronic hepatitis C to prevent the complications of cirrhosis and liver cancer in the future. What if I'm diagnosed with hepatitis C? Well, this is actually the best news, right? If you're diagnosed, you can be cured with a simple regimen of pills in as little as 8 to 12 weeks. You have a 98% chance of cure, and cure will stop progression of liver disease and allow your liver to heal. Last part of my talk, how do I find out if I have scarring of fat in my liver? So we have a tool called FibroScan. It is also known as transient elastography. I'm going to refer to the FibroScan just because it's easier to pronounce. So this is a tool that fits in the palm of my hand, and it sends a sound wave through the liver. The sound wave travels through the liver, and then it bounces back, and we can measure it, okay? So let's look at it in more detail. So if we pretend that the liver is a rubber ball here, right? If the liver is a nice and squishy rubber ball, like a healthy liver should be, the sound wave is going to take its time traveling through a nice squishy liver, okay? If on the other hand, the liver is hard, like a rubber ball, like a cirrhotic liver, then the sound wave is going to travel through the liver a lot faster, okay? So we can look at the speed of the sound wave travel and give you an estimate of how cirrhotic or how hard is your liver. We can do a similar thing with a fat, okay? Back to the rubber ball analogy. If our rubber ball is homogeneous without any inclusions, the sound wave is going to travel through the liver and it will not bump into anything. So the sound wave is not going to get smaller. However, if the rubber ball is full of inclusions, then the sound wave is going to bump into those inclusions and it's going to attenuate or get smaller. So we can correlate the degree of attenuation to the fattiness of your liver. So in conclusion, what have we learned today? There's many things that can damage the liver. COVID-19 pandemic is fueling the increase in alcoholic hepatitis and fatty liver disease. We are falling behind on testing for chronic hepatitis C during the pandemic. Neglected cases of liver disease may lead to cirrhosis and liver cancer. So I recommend that if you're concerned, ask your doctor to check your liver test. And that's how you handle liver. Okay. Thank you for listening to me. I am going to introduce my moderator, Daryl Chewy. Daryl is a fourth-year medical student at Torrey University of California. He's doing a hepatology rotation with us, and he has kindly agreed to help me with the question and answer portion.
All right, so we have our first question here in the chat. So they're asking, if I give up my pill form of probiotic, which plain yogurt is best? Is Activa good? Do we need to look for low or no sugar yogurt?
That's a great question. So it doesn't matter what brand of yogurt you buy, but it does matter if you buy it plain, right? Because the goal of the manufacturer of yogurt is to sell more yogurt, right? If we add sugar to it, it's going to taste better. So you're going to buy more of it, but then you're just eating dessert, which is not our goal. So the best thing you can do is buy plain yogurt. You can add some fruit or some honey or some granola to it to make it more palatable, but you are the one who is controlling how much sugar calories you're adding.
All right, so we have a question from Lena. What treatment do you use for Hep C? Is there a product you prefer?
Absolutely. So there are really not a whole lot of choices on the market. There are two products that we use, and one is called Epclusa, one is called Mavorite. Both of those products cover both choices. I mean, all the genotypes of hepatitis C, and they work great. When you see a hepatologist, there may be reasons for choosing one product over the other. But generally, those are excellent choices for treatment of hepatitis C. I apologize for using brand names. The generic names are very, very long.
Right. And then we also have a question from Elaine. So she says that on a recent liver panel, my ALT was 63 and everything else was normal. Metabolic panel was normal. I'm 62, slightly elevated cholesterol, but otherwise healthy. My doctor isn't concerned and also had a CT of the abdomen and chest and liver was normal. What are your thoughts? Thanks.
Got you. So it's a great question. And in fatty liver disease, especially in early fatty liver disease, the first thing that is going to rise is the ALT. And the ALT, normal ALT level for women is under 25. It's under 35 for men, right? So if you were asking me, I think given the fact that you said you had elevated cholesterol, I would be concerned that you may have early fatty liver disease. The best way to find out would be to undergo this transient elastography test or the fiber scan. Takes 15 minutes, it's not invasive, no needles involved, and you will get two pieces of information. One is how much fat is in my liver, and two, which is the more important question, is how much scarring is in my liver, right? And do I need to worry about it?
Okay, and then we also have a question from Anonymous. Is sugar harmful to the liver? What about naturally occurring sugars in fruit?
That's a really, really good question. And stick around, Kristen, our nutritionist, is going to talk more about it. Um, uh, my short answer is anything in excess is going to be harmful, right? So if you're eating fruit, this is probably one of the healthier ways that you can get sugar into your system compared to eating candy. But anything in excess is not ideal.
All right, and then we have some comments from Chris Cortez. He says that my mom has NASH and we struggle with the right amount of water intake to manage swelling and fight dehydration. And she takes several water pills and lactulose daily.
This is a really great question. Thank you for asking it. And this is a common misconception, right? What the question is a lot of patients with advanced liver disease or cirrhosis have trouble with building up fluid in their abdomen and their legs, right? So kind of the natural thought is, well, if I drink less water, I'm going to have less swelling. This is actually incorrect. The reason patients with liver cirrhosis accumulate fluid is the salt. In patients with cirrhosis, their bodies aren't able to process salt properly. So I encourage you to limit the salt in your mom's diet, not the water. There are a few cases when patients are really, really sick and their sodium level in their blood is very low, below 125. In those rare cases, do we limit the water, right? But for the vast majority of the cirrhotics, it is the salt that is the problem.
That's great. Thank you, Dr. Roytman. So I just wanted to, until anybody else wants to put a question in the Q&A or raise their hand, we're happy to open a mic up if you'd like to ask your question live to Dr. Roytman. Wanted to talk about the person that came to the Liver Expo that did the FibroScan test and was able to kind of address that issue. You don't have to talk in detail about this attendee, but why was it important that they showed up, and do you remember how that was addressed after the program?
Absolutely, absolutely. This is one of my favorite stories. Thank you for reminding me. So this patient, we met at the Liver Expo, and our live Liver Expo, back before the COVID-19 pandemic shut it down, included hepatitis C testing. So we could finger prick you and tell you in 20 minutes whether or not you had hepatitis C. And we also could put you through the FibroScan. So this patient underwent the FibroScan, found to have the fatty liver, and that was really kind of a life-changing experience for her. She changed her diet, she began exercising, she lost a lot of weight, which was all wonderful. Because she was in care, right? You know, we take pictures of your insides to make sure you don't develop liver cancer. As we said, you know, fatty liver disease is a risk factor for liver cancer. And what we found in her is that she had a very large mass on the opposite side of her liver. And lots of people got involved, including Dr. Fathi, who is going to speak later in this presentation. And we were able to have the patient undergo a very complex surgery that Dr. Fathi did, and to remove this massive tumor. So the patient is doing great. The tumor is out. Her liver is doing fantastic. And it's just really a very, very heartwarming story of how we were able to help one patient.
I love that story. I think it's really great, and it really speaks to the importance of this event, and also just getting the knowledge out there that this is a test that's easy to take. To piggyback off of that, I just wanted to ask from a patient perspective, how would I ask my provider? Would I just say, hey, I heard about this test, I would like one, or do you need a referral? How does that work with the FibroScan?
Absolutely. It's FibroScan, it's very easy to get a FibroScan. You do have to ask your provider, and it will be ordered just like an ultrasound or a CT scan, right? We have a FibroScan downtown at the community regional, and yeah, you do not need to see me. You see a nurse who performs the test. I look at all the tests and I will send a report to your doctor that tells them exactly what we've talked about before, how much fat is in the liver and how much scarring is in the liver.
So we have another question from an anonymous. So what is more accurate in diagnosing liver disease, a FibroScan or biopsy?
Well, this is a good question. We recently had an academic debate between a couple institutions in Northern California that was exactly about that issue. So let's think if roughly half of the Americans have a fatty liver, we cannot biopsy half of the Americans, right? It's expensive, it's invasive, people don't like needles. So this is not ideal. So FibroScan is probably as good of a correlate as it can get, right? So it's an excellent test that we can use on lots and lots of patients. Now, biopsy has its downsides, right? When we biopsy patients, outside of it being invasive and involving needles and whatnot, we sample only 1/50,000th of the liver, right? So there is an error in terms of that. Now, so I think for the most part, for most patients, especially if I'm suspecting fatty liver disease, I think FibroScan is an excellent diagnostic tool. Now, if I don't know what's wrong with a patient, they do not have fatty liver, they're not drinking, they do not have all the hepatitis, I've ruled out lots of other things and I still don't know, this is the time for the liver biopsy, right? Because FibroScan cannot tell me outside of the scarring and the steatosis, what else is wrong, right? So this is a good time for a liver biopsy.
All right. And then Nancy is also asking, is FibroScan covered by Medicare?
Yes. All right.
Wonderful. Well, looks like that's all the questions we have coming in for now. I think maybe we'll take just a couple minutes break before we get to the fitness segment so that we can give people a chance to set up their space if they wanted to go ahead and join us for that. So if you do want to participate in the fitness segment, it's only about 20 minutes. It should be nice and gentle for your Saturday morning. You'll just need a comfortable place with a little bit of space to move around and some water jugs if you have them around. If not, hey, grab a weight, grab a can, grab your own water bottle, grab something, that's fine. No big deal. So we'll get started with the fitness segment at 9:45. I'm going to give everyone just 2 minutes break and we'll see you back in a moment. Okay, everyone, welcome back. We are going to get started with our fitness segment. So grab your mat, grab some space. Oh, and by the way, thank you, Dr. Roytman. I apologize. I was so quick to jump on to the next segment. I want to thank you for your excellent talk and for answering your questions. And let the audience know if they have questions, continue to have questions, please put them in the Q&A. We will have more time at the end of the program today to answer those questions. So keep them coming. Okay, Dr. Roytman, are you ready to work out in your suit?
Absolutely.
Wonderful. Okay, thanks. Leland, can you please go ahead and run the fitness video? Wait, let me tell you about Tim Clark. I'm so sorry. Don't play it yet. We're lucky enough to have a presentation by Tim, and Tim is actually here with us today. Well, not with us today. He's at a Starbucks, I think. I think he's out riding a Harley or something. Hi, Tim. How are you? He's muted. But he's here to answer your questions after the program.
Oh, there we go.
Hey, Tim.
Good morning.
How are you?
I'm doing all right. Not bad.
Thanks so much for recording this video for us.
Oh,
Can you
happy
give
to
us
help.
a little intro about it before we get started?
Basically, the premise of the video is just to give you an opportunity to work out at home with minimal equipment. You know, even though things open up around town and gyms are open again, there's still, you know, a lot of people not comfortable working out in that environment due to COVID and that kind of thing. So working out at home is a very viable option. And oftentimes your body is your own gym and you take it everywhere you go. So that's kind of the premise of this video. And this combined with a couple of 1 gallon jugs of water that, I don't know, cost you less than $3 at a store and you are good to go. So that's it.
That's fantastic. Thank you, Tim, for giving us that option. And now let's watch the video from Tim, who's the manager of the Community Regional Medical Center Fitness Center. Okay, go for it, Leland.
Okay, so our first exercise is going to be a 45-degree chop with the water jug. Remember, if you need less weight, just pop the top, drain a little water out of it. Remember, when it gets empty, it gets a little sloshier as the water goes out of it. If you need more weight, just grab the other jug, match hands, and you got 16 pounds. So here we go. Nice straight arms, 45-degree arcing motion this way. Try to keep those arms nice and straight. If your elbow is bent, it's significantly easier. You want that nice, long, straight arc. We're gonna go 1 minute on, which means 30 seconds each side, and we're gonna take a 30-second break between each exercise. So keep going here. You should be feeling your arms, your shoulders, maybe a little bit of lower back and some torso rotation in this as well. Keep going, and there's your 30 seconds. We'll switch sides. There we go. Keep those arms nice and straight, nice and high. Vigorous motion. We want to try to get the heart rate up a little bit with this one. We've got some cardio stations in here intermixed with some resistance work. We want to get that heart rate up and try to keep it up during the whole workout. Keep going. You got 10 seconds on this one. Nice straight arms. Nice and vigorous. And we'll go. Last one. Good. That was our first exercise. Okay, so our next exercise is going to be a crunch with rotation. And we're still using a water jug. So straight above the shoulder. Start with shoulder blades flat on the ground, hips are flat on the ground. I'm just laying my arm out here just kind of as an outrigger. So I'm going to take this shoulder to that knee is what I'm trying to do. So come straight up, keep that weight above the shoulder the entire time. I'm taking that left shoulder to the right knee. And I'm just kind of rotating this way. So I'm taking this rib cage down to that hip if you want to think about it that way, if that helps. Keep that arm locked out nice and straight. Go up, crunch. Nice squeeze at the top. Come down. Again, we're going to do our 30 seconds per side. Let's go ahead and switch sides now. Straight above that shoulder again. So now we're going left shoulder, or I'm sorry, right shoulder to left knee. Up. Big squeeze at the top before you lower yourself. Good job. Go as high as you can off the floor with that shoulder blade and back down. 5 more seconds. And we'll call that time. And that was your second exercise. Good job. All right, we're gonna start in a seated position. This is just a squat press. So just straight up, press above your head once you stand, and back down. So we're gonna repeat, go as fast as you can. It's another one, it's gonna get the heart rate up. You're gonna feel this one in your shoulders. You might feel this in your core a little bit, because your core is stabilizing as you stand up. But big time shoulders and arms and some cardio. Again, just as fast as you can. Once you got your feet planted, don't move your feet. Just straight up. Adjust your weight as needed. You're over halfway there. About 20 seconds to go. Hang in there. Again, as fast as you can go. 10 seconds. Keep that core nice and tight. Draw that belly button to the spine. Protect that core. Last one. Nice job. All right, on to our next exercise. Okay, so this one is purely about cardio and getting that heart rate up. These are going to be mountain climbers. I've got a step here, modified a little bit. You can do it on a chair at home, a little easier. If you need a little tougher, just go straight from the ground and push up position for this. So all we're going to do is just back and forth this way. As fast as you can move those feet, and just exchange in place, tap and front and back. Now, if you're one that can't take impact and you need to not leave the ground, right, we can just do this at a fast walking pace, either up and back, or we can start from behind and tap forward and back, whichever you prefer. If you're not much of a dancer, this might be a little easier. But for the traditional mountain climber, getting that heart rate up, we're gonna start from here and go. So we're watching that clock. Going as fast as you can. Nice flat back on this. Let's go 10 more seconds. I think that should be about a minute. Keep going as fast as you can go. 3, 2, and 1. Good job. That was the last. We'll go on to the next exercise. Okay. So our next exercise is going to be lunges. I'm going to show you a couple different versions of lunges depending on your ability. We'll start with just a straight up stationary lunge to start. So I'm going to plant one toe. I'm going to come down. So I want a 90-degree angle here, 90-degree angle here. My back toes are kind of curled under. So from here, I'm just going to take my hips straight up and back down. So no resistance, just body weight on this one. If you need more resistance, I'm going to force do it with our jugs. Remember, if we've taken some water out, it's gonna be a little sloshier, it's gonna be a little tougher for our core to stabilize. If there's a little less water in there, it's more sloshy. But again, that's part of the fun. So I'm gonna come down. I don't really need to touch that knee to the ground. Just hover it right above the ground. Again, we're gonna do 30 seconds on each side. So now I'm gonna switch legs. I'm gonna show you a little tougher version. So I'm gonna drop one of the jugs. So this is gonna be a drop lunge. So I'm going to come down. I got my 90 and 90 back here. So I'm going to come up, do a lunge. I'm going to drop that and come up. And it's going to force you to shift your weight a little bit, take a little balance, as you can tell. Let's go one more of these. And down. Nice job. There's our lunges. And we'll move on to the next exercise. Okay. So the last exercise in our circuit are gonna be sumo squats. Again, if you need more weight, we'll just grab our second jug. So my toes are pointed slightly out. The key is I wanna keep my knees above my toes. So nice flat back as I go down. I'm gonna just touch the weight to the ground and up. I wanna keep my knees back over those toes. Do not let them come in knock-kneed style. Nice flat back. You can drive off the floor, push to those heels. Nice, powerful push. Engage those glutes, turn those knees out, drive through the heels. That will engage your glutes. There we go. We got about 30 seconds to go by my count. Good, nice flat back. This will be our last exercise in the circuit. Good. So after this, I'm gonna reset the timer, reset all the cameras, and I'm gonna do it with you. Try to keep pace with me on each exercise. Good, keep going. You got about 10 seconds left. Knees are out, big squeeze those glutes. Knees out, squeeze glutes. Nice flat back, nice tight tummy, protect your core. And last one, boom, that's it. All right, so I'm gonna reset everything and I'll do it with you at pace in the next round. Can you get some music, a little more attitude for the workout, please? Whoa, easy. Family show. That'll work. All right, good job today. That was a right proper HIIT workout. If you appreciated that, do all the obligatory YouTube things like, share, subscribe, whatever all those things are, I don't know. Thanks again for joining us today. Next workout in the series, you'll probably either see from Puva or Andrew, because you guys are just flat out wearing me out. I'll recover and do one again soon, I promise. Thanks again for joining us. We love you guys. We hope you stay safe, stay well, and we hope to see you very soon in here in the fitness center. Thanks again. Peace out.
Tim, are you exhausted from that workout you just did?
Of course, that's what it's for.
I don't see
I
your
like-
sweat dripping, so I don't know.
I like how the goatee magically changes from then to now too.
Master of disguise. If
That's
nothing
it, right.
else. Well, that was a great video. I did most of it, I swear, except for the sumos at the very last round. And my blood is pumping. I'm warm right now. I don't know. Dr. Roytman, did you do any of the squats in your office there?
I did not. It's just too hard in a suit.
You'll have
Slacker.
So for the attendee that asked if this will be available, absolutely. We're going to share this whole recording with everyone after the program. And Tim, I don't know, are you sharing that YouTube link with everyone? The one where you're posting the videos for CMC Fitness?
They are on just a YouTube channel that anybody can see, as well as with the rest of the video content. I think we have 25 or 26 videos posted online.
Amazing. Oh my
Yeah.
gosh. Okay, so I'll get that link from Tim after the program, and I'll be sure to share it with all of you. Unless do you know the tag offhand? Tim?
I sure don't. No, I don't. Sorry.
I might be
I'm
able to
not-
find it. I'll take a look and
Okay.
see if I can find it, and I'll share it with everyone because it's really wonderful. They're short enough videos that you can do any time of the day. If you have an extra 15, 20 minutes, they're mostly shortened, right? They're pretty
We've got kind of a blend of stuff. We got some educational stuff that's not workouts
Amazing.
at all. We've got some workout videos that I think our shortest one is about 5 or 6 minutes, up to like 20 minutes, I think is our longest one. So there's plenty there for anybody, really.
That's
yeah.
wonderful. Thanks, Tim. Well, I have a couple
Yeah.
questions, unless we get some other folks chiming in here with other questions as well. And Dr. Roytman, you can feel free to chime in with any of your fitness questions. These are more, I just want to know. So I'm just going to ask you, and hopefully other people want to know them too. So can you give us some low impact fitness options for those that might have some mobility or balance issues, or just kind of are starting out? Are there
Sure.
other low impact options for fitness?
Yeah. So when you think about high impact versus low impact, and unfortunately, low impact exercise sometimes it's a bad rap and seen as not as intense or whatever. But if anybody's ever taken a spin class and tried to keep up with a good spin instructor, that's low impact, and that's definitely high energy, good calorie burn. A good 500 calories in an hour easily. So think about low impact is any form of cardio where you have at least one foot on the ground the entire time. So walking, hiking would qualify. Think about rowing machine would qualify. Even if you had a kayak, that would qualify. A bicycle, anything like that. So that's kind of the definition between low and high impact, is if your body is actually completely leaving the ground at some point during the exercise. So
That's great. Thank you, Tim, for those options.
yeah.
And now I have a question about kind of if you're going to the gym regularly, the way in which you should do it. So I've heard a few different things. One is kind of focus on particular muscle groups each day. And the
Okay.
other is kind of spreading it out and doing a full body workout per workout. Like what do you recommend, or what do you have to say about that?
So that is largely dependent on the goals and aspirations of the person going to the gym. Heavily dictates the style of workout, whether you're doing a split routine, whether you're doing full body routine. And even when you talk about split routines, if we're talking about somebody that maybe is let's say a bodybuilder, they may go to the gym and spend 2 to 3 hours just working on chest and triceps one day, the next day maybe back and biceps, shoulders and abs the next day, and legs the fourth day, maybe a rest day and come back to it the beginning again. But that's very specialized. Someone that's looking for more just general fitness, It might be a full body routine one day, the next day maybe cardio, and the day after another full body routine. If you're doing a full body routine all in one day, I wouldn't necessarily go back the next day and do that again. So what we're doing when we're in the gym is we're applying resistance or a load to your body it doesn't normally get in its everyday life. And we actually, the goal is in that gym session to actually tear down muscle tissue on the microscopic level, create a little bit of tears in those contractile proteins. And with 24 hours of proper rest and nutrition, your body knits itself back together again a little bit better and stronger and faster and all those Olympic themed things than it was before you did that gym session. So with that in mind, if I went in day after day after day and I thrashed the same muscle group every day after day, I'm tearing down, I'm tearing down, I'm tearing down. I'm never giving my body a chance for that recovery, which I need that recovery for my body to create adaptations to get stronger and that kind of thing. So that kind of shows the two different polar extremes of working out. But yeah, your question is very, very, very goal oriented. Every sport has its own protocol, I guess you could say. So it's gonna be very different from person to person. Hope that answered that question. So kind of a broad paint stroke answer.
That's
but,
a great answer. And I also
yeah.
feel like it addresses something that I found interesting as a non-physician who didn't know this was really happening. But when you think of muscles tearing, you don't necessarily, or maybe not muscles, but just, kind of moving apart or however you wanted to phrase it when
Yeah.
you're working that muscle out to be able to stitch back together stronger. That's a really interesting visual to me that I never really thought about it that way, that if I were to go and work the same muscles every day, that I'm not giving it a chance to rebuild
Yeah.
a bit stronger. So that's really helpful to me.
Yeah. And to kind of expand on that a little bit too. So that muscle burn or ache you're feeling during the workout, right? That's going to be the products of muscle contraction, lactic acid, that kind of thing building up in your body, not clearing it as fast as you'd like. If you're feeling that achy and kind of that, I don't know, I don't want to call it pain, maybe discomfort, beyond like 72 hours after that initial workout, then you need to look at what's going on with your recovery. Are you not hydrated enough? Your nutrition isn't good enough. You're not sleeping well enough. Something like that is going on. The other thing that kind of affect that, how fast you bounce back and recover, your age, your workout experience. Someone who's been in the gym a lot, like I have, is going to recover a little faster than someone's like fresh off the couch. All those things affect it as well as like how fast you can come back from a workout. So
That makes
there's a lot to it. Yeah.
I have a question from an attendee who's asking
Okay.
for any recommendations for specific exercises for osteopenia or osteoporosis.
That's a good question.
It is. So I'm asking
Yeah.
you.
Yeah.
But hey, not that you're a bone expert, so
Yeah.
it's okay if you don't have an answer, but maybe just
Yeah.
other low impact options, or I'm not
It's-
sure, Dr. Roytman, do you want to weigh in on any of that? Or
Yeah, it's definitely gonna be low impact options for sure. I wouldn't do anything until you were cleared by a physician first. But yeah, it's definitely gonna be low impact options. And I think, over time, you can progress your exercise selections to get a little more aggressive, but you're really gonna have to pay attention to your body on that, and you can't progress too quickly on that. Yeah, that's
maybe
a tough
things
one.
like yoga or other things that are kind of on the
I think-
mat. Dr. Roytman, what do you think?
I'll jump in. So I think the way to keep our bones strong and healthy is by engaging in weight-bearing exercise, right?
Yes, for sure. Yeah.
Right. So, and it depends on kind of where you're starting, as Tim pointed out, if you're fresh off the couch, right? Even walking, right? Because your own body weight participates, this would still be considered a weight-bearing exercise, right?
Yep.
And as you get stronger, getting more, weight workout into your routine would definitely go a long ways of keeping your bone disease from progressing.
And that question kind of makes me think of a guy that I used to race bicycles a whole lot, and a local guy in town a master's division guy, older guy, and his workouts were always on the bike. And being that was non-impact, as he got older, he actually had osteoporosis issues because he didn't really do anything else for exercise. He didn't lift, he didn't do any of these other things. So even though he's very, very active, that can still happen if you're doing non-weight bearing movements or exercises as well.
Exactly. Weight bearing exercise. So Tim, thank you so much for doing the video and for sticking around for questions. I just want to leave everybody with the last thought. You guys saw that the last shot of the video, Tim was sweating, and
Yes.
you can that he was a little short of breath, right? So these are the things that I am looking when I'm recommending that you engage in cardiovascular exercise. I want you to look like Tim did at the end of the video. Okay, thank you so much. We will move on to the next segment of our program. And it is my absolute pleasure to introduce my dear friend and colleague, Dr. Amir Fathi. Dr. Fathi is a clinical associate professor of surgery at UCSF Fresno Medical Education Program. He's board certified general surgeon from Case Western Reserve University in Cleveland and has completed his fellowship training in hepatopancreatobiliary surgery and Medical College of Wisconsin. Dr. Fathi is the medical director for Oncology System of Care and Clovis Cancer Institute, as well as the chairman for Oncology Advisory Council for Community Medical Centers. Nationally, he serves as a surveyor for Commission on Cancer for American College of Surgeons. Dr. Fathi is a faculty executive, facility executive chair for Community Regional Medical Center, Central Valley of California's only SafeNet hospital. As a surgeon champion for both the National Surgical Quality Improvement Project and Enhanced Recovery After Surgery program, Dr. Fathi focuses on complex surgeries of tumors of the liver, bile ducts, gallbladder, pancreas, and stomach, along with complex abdominal wall reconstructions and hernia surgeries. We're very lucky to have him speak today. Welcome, Dr. Fathi.
Well, thank you so much. It's an honor to be here. Thanks for involving me in this Liver Expo. I've been following this peripherally for a few years, and every year it gets more fruitful, more popular, and we hear from all sort of people across town and sometimes even out of town that they really enjoy being part of this. Well, obviously, because of the COVID, we have to do this as a virtual thing, but hopefully we're going to see the days that we're coming back, and Dr. Roytman is doing FibroScan on everyone to show how stiff their liver is. She asked me to talk about pancreas and pancreatic cancer. So since it's a very obscure organ, I decided to put a talk together to introduce what pancreas is, what it does, what kind of diseases can be associated with it. She wanted me to focus more on the screening part, what can we do to avoid pancreatic cancer, and then tell you a little bit about what we do as in the surgery world in order to be able to deal with this disease. Sorry, a lot of construction is going on in my room, in our home, so I'm sitting in my son's room and trying to isolate myself so you guys don't hear the drilling and those sort of stuff. So you're going to see a lot of if you hear some funny stuff, that's my son, and then drilling. So I apologize for the noise going on. Let me share my screen now. Let's see. Very well. We will go to presentation. I guess we start from the questions. There you go. We'll talk about the vice and virtue of this very temperamental organ. Pancreas is a fascinating organ. It weighs, I would say, 60 grams, 70 grams, a few ounces, and it is 3-4 inches long. It sits on your spine and regulates a lot of hormones and digestion for you. In order to be able to understand what part of this temperamental organ is disease, anatomically we divide it to multiple sections based on its association with the gut, blood vessels, and whatnot. So we mainly say if something that involves pancreatic head, body, or tail. Despite being very small, we still give him different body types and body locations. It sits right behind the stomach. It interacts intimately with your bile duct, with your stomach, and its productions, its juice per se, enters the first part of our GI system, which is duodenum. It is I say it's a fascinating organ because this little thing has dual function. So it has a big part of it that we call it exocrine function, accounts for 85% of its job, and it's done by acinar cells and ductal tissue. And what it does, it produces enzymes and liquid to digest our food. As you know, there's significant amount of acidity to the stomach content. So the first portion of the gut that sees the food after stomach is duodenum. And that's where the highly acidic food with the high acid content arrives in the GI system. So pancreas produces a lot of water and sodium bicarbonate in order to nullify that acid, so it won't hurt the rest of the GI system. Because if you remember, the stomach has the protection system against the acid, but rest of the gut doesn't. So one of the most important jobs of pancreas is to nullify that acid. And then a small portion of the pancreas, which we call it endocrine function, or the islets of Langerhans, produces hormones, which the most important one of them is insulin, which helps the metabolism of our sugar. And you know, if that part is not functioning, people will have diabetes. So this small organ not only helps to digest our food and help us with eating, but also produces very important hormones such as insulin in order to help with the metabolism of sugar. Just like any other solid organ in our body, pancreas is susceptible to have cancers. And in order to bring it to your attention, I'm going to talk about our valley. Every year, since we run the cancer center over here, I'm very interested in the stats of cancer in our valley. Every year, more than 10,000 Central Valley residents are diagnosed with invasive cancer. And this is invasive cancer, not this small skin cancer that can be dealt in an outpatient clinic. Over 10,000 people in the valley get invasive cancers, and around 4,000 deaths cases happen in the valley every year from the cancer. So it is one of the serious issues of public health in the valley that we are dealing with. And as you know, population of the Fresno, population of the valley is growing exponentially, and you see these houses popping up everywhere. So these numbers that I'm giving you are projected to expand at least 15% per year based on the growth that we are seeing in the valley. So as I said, pancreas has dual function and two types of major cells. Therefore, two different types of cancer can arise from the pancreas. The most common one that you've heard about it, this dismal disease that kills people quickly, is the one that arises from that digestion part of the pancreas, and we call it pancreatic adenocarcinoma. The cancer that arises from the GI part. And then we have the rarer type of tumor. And if you remember, only 2% of the pancreas takes care of the hormonal part. So the chance that that 2% can have cancer is rare, but it still can happen. So when we see a patient with pancreatic cancer, the first thing that we do is to determine where this cancer is coming from and what type of cells are involved in the cancer production. American Cancer Society every year gives a projected cancer death outlook. Based on the great work that has been done on breast cancer, colorectal cancer, prostate cancer, and lung cancer, the projected death cases for these cancers are going to be decreasing. On the other hand, the death from the pancreas is projected to increase. You know, people are more aware about the breast. More females are doing soft breast exams. Less and less people are smoking, and we are more aware about the colorectal cancer, and people pay attention to the blood in their stool. So in 2030, the American Cancer Society projects that the major cancers are going to decrease while pancreas is going to outnumber the breast cancer death. So it is a real deal, and we really need to pay attention to this cancer. It is a very deadly cancer. It is one of the cancers that is really associated with the smoking. Usually when people talk about a smoking, everyone talks about the lung cancer, but interestingly enough, the carcinogens or the stuff that cause cancer in the cigarette concentrate in pancreas more than lung. So smoking causes a significant amount of lung cancer. Every year, around 60,000 people are diagnosed worldwide, and it is one of the deadliest cancers. As of now, the lowest survival rate for any solid tumor cancer belongs to pancreas. So it is a deadly disease, and we really need to pay attention to the family history, to the symptoms that our body tells us to, God forbid, not to ignore this disease. One of the reasons that this disease is very deadly is because we don't get to it fast enough. It doesn't have very specific symptoms, such as colon cancer, right? If someone has colon cancer, most probably they see blood in their stool and they pay attention to that. But pancreas, and we're going to talk about symptomatology, has very vague symptoms. So people don't pay attention, and usually they come to see a doctor when the cat is out of bag and we're in a very bad stage that nothing can be done. There are a lot of famous people who have died from pancreatic cancer. I have some pictures over here. I'm sure you knew or heard about some of them. And when we talk about the pancreatic cancer, a very dismal picture comes to the mind in the news and whatnot, which is true. So let's talk a little bit about this this cancer that is very deadly. Again, one of the most important things that I want you guys to take from today's talk is to pay attention to your body. If you're losing weight, if new stuff are happening to you, just don't attribute it to a luck that, oh great, I'm losing weight right now. Or if you're having symptoms, you're having pain, don't just ignore it. If you're not able to digest your food, if you're having problems with digestion, don't just say, well, that was the bad quesadilla that I ate last week. No, that's not the case. You really, really need to pay attention to what your body is telling you. There are three major things that everyone needs to know about it. If someone gets jaundice, meaning that if their skin or eyes start getting yellow, that's a very, very concerning sign. If someone has upper abdominal or back pain that persists, something that it just keeps gnawing there, that is something that you really need to pay attention to. Weight loss. Obviously, COVID caused all of us to gain weight now, and everyone perpetually wants to lose weight, including me. But if someone starts losing significant amount of weight, something like 30, 40 pounds in a year, don't be excited that, okay, finally I'm losing weight. There's something wrong going on. Again, your body's telling you something that you need to pay attention. And if someone gets new onset diabetes, usually the pancreatic cancer gets ignored or not paid enough attention. If something is wrong with the pancreas and affecting those endocrine cells, that might be something affecting the entire gland. So weight loss, digestion problems, yellowing of your skin, and diabetes. These are the things that we need to pay attention and think about pancreatic cancer. So what do we do? I mean, yes, it's a deadly disease, but can we catch this disease before it gets to us? Yes and no, because it's a rare cancer, still a rare cancer compared to the breast or colon. We don't screen everyone. Like in breast, every female around 50 years of age. In colon cancer, everyone at the age 50, which both of them are decreasing their numbers now, has to get checked. Every female around age 40, 50, they need to have a mammogram. But for pancreas, we don't have that. We only save the screening for high-risk patients. And I'm going to tell you who these high-risk patients are. If someone has pancreatic cancer in their first-degree relatives, they are considered high risk. So if your loved ones, in your siblings, in your parents, uncle, aunt, someone has pancreatic cancer, you really need to be aware of it and ask and talk to your doctor about that. there are certain genetic syndromes, there are certain genetic disease that cause pancreatic cancer as a big picture. One is Peutz-Jeghers syndrome. It's a difficult name to say, but generally these are the people that inside their mouth or their mucosa turns dark. They have dark spots at their mucosa. If someone has familial pancreatitis, if someone gets pancreatitis after pancreatitis and after pancreatitis, we really need to dig into why the patient or their loved ones are having multiple episodes of pancreatitis, because there could be a genetic mutation associated with that can cause pancreatic cancer. And then I'm sure you guys have heard the BRCA genes that are associated with breast cancer. Same genes that are associated with breast cancer can cause pancreatic cancer as well. So if there is a breast cancer in your family that they've been told that this is a genetic disease, we need to pay attention to make sure that the other cancer are considered as well. And multiple melanoma. If someone in your family or yourself are having multiple melanomas that require surgery, we need to think about pancreatic cancer as well. So it was a little bit of a long-winded answer, but the bottom line is the screening for pancreatic cancer is not like breast and colon. Not every single person needs to be screened, but if you have someone, the short answer is if you have someone between your loved ones and your family members who has pancreatic cancer or a specific genetic disease, it's worth looking into it not to miss the pancreatic cancer, because if we miss it, the outcomes are devastating. So let's say that we have a high risk patient. When do we start? Usually we start the screening around 50 years, or the rule of thumb is 10 years younger than the age that the relative was developed. This is usually the rule for a lot of other solid tumors, for example, Lynch syndrome or colon cancer, that we start at 50. And if there is one, we go 10 years younger than that to make sure that we catch these genetic abnormalities. And on that mucosa turning black one, that's the only one that we start really, really early in terms of screening. But again, it's more important for you to pay attention to your body rather than worried about getting an MRI. So let's say, God forbid, someone has pancreatic cancer. What is the treatment? So if someone gets pancreatic cancer, the key is, just like any other solid organ tumor, to cut it out. At this day and age, there's nothing better than cutting out a tumor, a solid organ tumor, not like the blood malignancies. We like to cut it out and follow it with chemotherapy. But if the chemotherapy doesn't work, then we will focus on the chemotherapy, and chemotherapy will be the mainstay of treatment. When we talk about the pancreas surgery, there are multiple procedures that we do. It is a very involved procedure. It usually involves hours and hours of operation, because pancreas is, again, as I said, it's a very temperamental organ. It's hiding behind a lot of other organs. It wraps around a lot of vasculature. So the surgery is really difficult in terms of remove a part of pancreas. We usually, the surgeries that we do involve 4 different types. One we call it Whipple. That's the one that we remove the head of the pancreas. The second is a distal, when we remove, let me see. Okay, these questions are not, I just realized the questions and answers, but someone is asking about the raffle, not me. Okay, very well. So we remove the head of the pancreas, we remove the tail of the pancreas, we can remove the middle of the pancreas, and in some cases, we are able to remove the entirety of the pancreas if needed. A lot of people think, well, can I live without pancreas? The answer is yes. We can remove the entire pancreas, then we have to give the patient pancreatic enzymes in order to help the digestion, and they need to be under very tight control for diabetes. As long as we control the diabetes, as long as we give the enzymes, people can live with the pancreas, or at least part of their pancreas. One interesting thing is we only need 20% of our pancreas to not to turn diabetic. We can remove up to 80% of the pancreas and patient will be okay. So again, it's a fascinating organ that even 20% of that can take over the function of the rest of it. Unlike liver, it does not regenerate. The fascinating thing about liver is if you cut part of the liver off, it will regrow. But if you cut part of the pancreas, it does not regrow, and whatever is left need to basically take over the function. I'm going to show you some pictures now of what we do. This is where your pancreas sits. We're going to start over here. Let me see. Okay, perfect. So we have a moderator who will read the questions for me. Okay, so this is a normal anatomy on the left side of the screen. I'm not sure. I hope you guys are seeing my cursor. Are you guys able to see my cursor? Summer or Dr. Roytman?
Yes.
Okay, very well. So this is your liver. This one is your stomach, and the yellow thing behind the stomach is the pancreas. As you can see, the head of the pancreas is very entangled with a lot of stuff. So in order to remove the head of the pancreas, we basically cut the bottom of the stomach, first part of the bowel, the entire, and then take it out and reconnect it together. This is an example of people who have the tumor at the tail of the pancreas. Because tail of the pancreas is very intimately associated with the spleen, we have to remove the spleen and tail together. This is an actual representation from surgery of myself that we remove the spleen and the tumor at the tail of the pancreas. And sometimes we're even able to remove the middle part of the pancreas. This is another patient that we removed the middle of the pancreas. And this is a case for total pancreatectomy that we removed. As you remember from the schematic picture, we removed the entirety of the pancreas. And these are the vessels that were involved with the pancreas that are left there alone. That this patient really needs to go on a very tight diabetes control and also pancreatic enzymes for the rest of their life. Well, I before finish my talk, I really wanted to focus on what I told you before. It is a deadly disease. The survival is very low. From all pancreatic cancer comers, if we offer surgery, chemotherapy, whatever that we can do, the 5-year survival of these patients with all of the treatment is only 18%. So only 18% of these patients live despite whatever we do for them. It's a very deadly disease. So it is imperative for us to be able to catch this disease on an earlier stage. Unfortunately, the symptoms of the pancreatic cancer are not specific. It's not like colon cancer that people get blood in their stool, or in females like breast cancer that they can feel a mass in their breast. So the symptomatology is very vague. That's why it's important for all of us to really pay attention to what our body is telling us, what type of symptoms we are having, to be able to catch this disease in an earlier stage. If we catch it in an earlier stage, that is fantastic. We'll be able to do a lot of stuff. But if the cancer comes out of the pancreas and goes to the liver or other part of the body and it becomes a stage 4 disease, there's very little that we can do for the patient. So it's imperative, if you're losing weight, don't be too happy about losing weight. You really need to pay attention to see what's happening around you. There might be a lot of sharks involved with the symptoms that you're seeing to protect your health for the future. The other thing that I didn't touch upon is pancreatitis. We talked a lot about the cancer. Pancreatitis is the inflammation of the gland. It is associated with alcohol. So people who drink a lot of alcohol, they really need to pay attention to their liver, that Dr. Roytman, I'm sure, have told you a lot of stuff, and also to their pancreas. I hope this was helpful. Let's see if we can entertain any questions for next 10, 15 minutes.
Yeah, thanks for the great talk, Dr. Fathi. I'm just going to read off some of the questions that
Sure.
the attendees have asked. A friend recommended we take pancreatic enzymes. What is their function, and do you recommend it?
Okay, very, very nice. Very good question. Let me figure out. I'm not sharing the screen anymore, do I? Or okay, very well. So pancreatic enzymes are basically made of pig's pancreas. It is a very safe medication. As a matter of fact, it's not that type of medication, it's just enzymes. They get the pig's pancreas, I don't know how they get it out, but they smush it, they mix it, and they extract the pancreatic enzymes off of it. In patients who have pancreatitis, in patients who have pancreatic cancer, in patients who have autoimmune disease, in patients who have diabetes, their pancreas does not produce, because pancreas is sick, it does not produce enough enzymes. So they need to get extra enzymes to digest their meals. You have to, again, pay attention to your symptoms. If your pancreas is not producing enough enzymes, most of you won't be able to digest your fatty meals. So fat is going to be compromised. So these are the people that if they eat a big burger or a big fatty meal, they will feel that food is running through them. They have to run to the bathroom. They get bloating. After eating, they get bloating. They have a lot of flatulence. And sometimes they will see oil droplets in the toilet bowl, meaning that like olive oil on the water on their stool, they'll see oil droplets. These are the symptoms of not having enough pancreatic enzymes. And that is when we have to supplement the patient with these pancreatic enzyme supplementation. In a normal person, usually pancreas creates enough enzymes that you don't need it. But if you're suffering from a disease that is affecting your pancreas, if you had gastric bypass, if you had cystic fibrosis, if you had, again, pancreatic surgery, yes, you're going to need it. And the key is to pay attention to your bowel habits and stool quality to determine whether you need it or not. I hope that answered the question.
Thank you, Dr. Fathi. I think I just want to make sure that the patients who do not have pancreatic insufficiency, right? There's no need for pancreatic enzyme supplementation.
Not really, no.
Mm-hmm.
Okay, so we also have a question, seems like it's in regards to pancreatic cancer.
Okay.
So they're asking what specific areas of the back and abdomen will have pain?
So it's going to be upper back and upper belly, right under your breastbone. And the same corresponding area on your back. Okay. Not lower abdomen, not towards your pelvis. It is in the upper abdomen around your breastbone.
And then we also have another question. Is there evidence that daily intake of lemon water in the morning cleanses the liver?
I guess that's a question for Dr. Roytman. She knows much more about these cleansing stuff than me. I'm just I don't know. There's tremendous amount of stuff out on the literature, on the books regarding these cleansing, detoxifying stuff, but none of that, to be honest, at least in the medical literature, none of that is proven. We don't, as doctor, we don't tell anyone to go to cleanse their liver or whatnot, or their pancreas. So I'm not sure. I can't say it's good or bad. I'm sure lemon is good for you at some point, but I don't know if that will detox your liver.
Okay. I agree with that answer 100%. And since we're on the topic, I'll elaborate. There is no harm in drinking lemon juice, lemon water. If you like the taste, it provides you with some vitamin C, which may help with immune functioning, but there is no role in drinking lemon water for cleansing your liver. Since we're on the subject of cleansing, I really want you folks to avoid buying any type of cleansing things on the internet at the GNC that may help your liver. Those things are not scientifically proven to do anything and could potentially be harmful to your health. Thank you. Back to Dr. Fathi.
Yeah, so we have another question. What is pancreatitis and what are the symptoms?
That's a very good question. I think I had on this. Can I share my screen one more time? Let's see. I had a picture. I had a pancreatitis talk before. There you go. Okay, so if you look at this slide, our pancreas produces juice, right, and insulin in order to digest our meals. This pancreatic juice is extremely digestive. So if it does not empty out of the pancreas, it will start digesting your own pancreas. So that is the whole point. If you have a situation like gallstones or cystic fibrosis, or something that blocks the pancreatic juice from exiting your pancreas, just like this picture that I have over here. This is the little cute gallbladder comes in, and then pancreas is doing its job, and all of a sudden gallbladder says, hey, I have some gifts for you, and then blocks the entire thing. The pancreatic juice will just blow off at the face of the pancreas, and it start digesting your own pancreas will make you really, really angry. So your pancreatic cells will start dying and will have significant inflammation of the pancreas. Or if you drink a toxin like alcohol, if you keep drinking alcohol, which is toxin to your pancreas, just the same way that the enzyme blew on the pancreatic face, those enzymes are going to kill this. Those toxins are going to kill the pancreatic cells and cause significant inflammation of the pancreas. So bottom line is, if your pancreas is angry, if your pancreas has significant inflammation, it's called pancreatitis. That is the worst type of pain that someone can experience. Basically, I've talked to multiple females, it is the pain in the belly with the full-blown pancreatitis is worse than giving birth. So it's like a horse kicked you in the belly. And it's associated either with gallstones or alcohol in the United States. I hope that answered.
Okay, so we have another question.
Yes.
So are they working on a screening blood or other type of test so that it becomes part of an annual screening, like lipid or liver panels?
Yes, very good question. As a matter of fact, we are part of the study as well at UCSF Fresno. So the bottom line is, the basics of this research is, if you have a tumor inside your body, some of that tumor cells will die and release the stuff in your blood. So if we can catch tumor-related genes or proteins in the blood, we can catch the tumor before having a clinical presentation. That is the bottom line. There's a lot of research going on there. Yes, in the future, there's going to be a blood test that will be able to detect the pancreatic cancer, more specific KRAS mutation or cell-free DNA. In the future, but it's not validated or commercially available yet. So you still need to pay attention to your.
All right, thanks. And then we have another question from Anonymous. A quick question about non-invasive hernia procedures. Do you use mesh or no mesh in your hernia procedures?
That's $1 million question. Dr. Roytman won't let me spend a half an hour today about the mesh or no mesh. Mesh is just to answer broadly, mesh is a double-edged sword. You ought to know when to use them and not to use. The trend is not to use it if you don't need it, but you got to know that in some hernias, if you don't use the mesh, the hernia will be back, and all of that work that you've done will go down the drain.
Okay. And then next question from Anonymous. What is leaky gut syndrome? Seeing this all over social media.
I am not sure. Maybe Dr. Roytman or Dr. Summer will know about leaky guts. I don't know that much.
I think sometimes in the liver disease space, in patients who have advanced cirrhosis, we know that the bacteria that is supposed to be inside the gut can leak out to the outside of gut and cause what's called spontaneous bacterial peritonitis. So that's within the space of liver disease that I can comment on.
Okay.
Daryl, any other questions?
Yeah, so a question from Judy. She says, I had a Whipple procedure and the tumor was not cancerous. Should my adult children be screened for pancreatic cancer? And can a non-cancerous tumor change into a cancerous one over time?
Hi, Judy. Yes, the answer to all those questions is yes. The most probably the reason that you have undergone a Whipple procedure is because you had a precancerous lesion that wasn't cancer, and thank God they removed it before turning to the cancer. Because if you remove something that is not cancer, your survival is 100%, but if that turns to cancer, then your survival drops to 18%. So that's why we preemptively remove stuff that are in the pancreas that can turn to cancer. And regarding your children, it depends on what they took out of you. So that's a question to your surgeon or person who manages you to tell you exactly what that is, and and to see if that can run between the generations. Most probably, yes, your kids needs to be looked at as well.
So I think that's all the questions we have for Dr. Fathi. I think we have some questions that are more for Dr. Roytman if we have time to answer those right now.
I think there was one more in the
Oh.
chat that I just saw come in, so no worries, Daryl. Would milk thistle help with elevated liver enzymes?
I remember my wife was taking that to increase the breast milk when we were pregnant. I'm not sure about the liver enzymes. So I highly doubt that milk thistle has anything to do with the liver enzymes, but we'll let Dr. Roytman answer.
I'll take that. And I think we have about 9 minutes, right, Summer, before the break. So Daryl, if you want to bring up the remaining liver questions, that would be a good time to do it. So milk thistle. First of all, in the United States, dietary supplements, and milk thistle is a dietary supplement, are not evaluated or approved by the FDA. So basically, anybody can put anything into a pill form, slap a label on it, and sell it to you online, on GNC, in a regular pharmacy, because there is no FDA oversight. So you are taking your life into your own hands when you're taking dietary supplements that are not prescribed to you by the doctor. When we worry about the dietary supplements, we worry primarily about what's called multi-ingredient dietary supplements, which means there's lots of stuff in one pill. And those, the major offenders are those that are used for weight loss, and those are used to enhance athletic performance. So this is the background for dietary supplement in general. With regards to milk thistle is probably the most studied dietary supplement in the history of dietary supplements. Well, the good news is it is very safe. Well, the less good news, it is not effective. It does not do anything for your liver health. However, it does deplete your wallet. The only thing that the milk thistle has ever been proven to do, so focus here, is if it is given intravenously to patients with active hepatitis C, it temporarily reduces their viral load. So this is the only thing the milk thistle has ever been proven to do. So I do not recommend milk thistle because there has been many studies that prove that it is safe but not effective.
All right, and then we have a question from Deanna. So how often do you recommend FibroScans? For HCC screening, it's recommended patients complete a liver ultrasound every 6 months. We only do a baseline FibroScan and then alternate with a liver ultrasound. What is your recommendation?
This is a great question. So ultrasound or CT and MRI and FibroScan are two different things. They are used for two different things. So let's talk about first the imaging, ultrasound, CT, and MRI. Those are the things that allow us to directly look at the liver. And this is how we find cancer potentially, right? So those for patients with advanced liver disease or other risk factors for liver cancer should be done every 6 months, along with a special blood test called AFP or alpha fetoprotein. Now, the FibroScan, remember how we talked about it's a sound wave technology. So we actually do not see the liver in the same way that we see it on the CT or ultrasound or an MRI. So FibroScan cannot be used for screening for liver cancer. It can be used for evaluating the patients for liver scarring and liver fat. There are no recommendations at this point of how often to repeat the FibroScans. What I do in my practice, if things have changed dramatically, right? If my patient has lost the recommended 10% of their total body weight, the enzymes look better, I'm really happy with it, I will repeat the FibroScan to prove to myself and to the patient that we have done a good job. On the other hand, right, If my patient continues to drink alcohol, right, has multiple relapses, we're not able to stop drinking. I worry about the disease progression. So in that case, I will again repeat the fiber scan to see where we're at this point. Probably the closest I can see repeating fiber scan is every 12 to 18 months because changes in the liver are slow.
Okay, and then we have a question from Anonymous. If my FibroScan indicates stage 1 or 2 liver disease, and my biopsy indicated a NAFLD activity score of 1, which should I believe?
So if I understand correctly, you had a fiber scan and a liver biopsy. And neither one of those tests is 100% perfect, right? In a biopsy, we sample 1/50,000th of the liver. The fiber scan sample is a little larger, but it is still a small sample. I think what is good about your situation is both of the tests tell us that you have early liver disease, early fibrosis. Anything from 0 to 2 is considered early disease. So we don't worry about cirrhosis and its complications at this time. And whatever the cause of the underlying liver disease, it sounds like it may be fatty liver. This is a great time to go with this lifestyle modifications, weight loss, exercise, and to prevent and ideally reverse the fibrosis.
All right, and then we have a question from Cheryl. What causes multiple liver cysts?
This is a good question. And Dr. Fathi, please free to jump in here.
No, I'm learning from you.
Thank you. I think the short answer, we really don't know. There are rare genetic conditions where people develop literally hundreds of cysts, right? It's a polycystic liver disease and polycystic kidney disease. Those are rare and genetic. There are lots of people who have 1, 2, or few cysts in the liver. Cysts are simply just bubbles in your liver. They do not turn into cancer. They do not rupture. And generally, they do not cause problems. So we know they're there, and we generally don't worry about them unless they have concerning characteristics on imaging. If the characteristics are concerning, then we may consider sampling one of those cysts with a liver biopsy and figure out what's going on. Dr. Fathi?
Yeah, that's a very good, very comprehensive answer. And yeah, I think rather than focusing on why we have the liver cysts, I think we want to make sure that those liver cysts don't do anything funny in the future. So there are a lot of cysts that we will look at them and it's like, yeah, you're fine, but they can turn to cancer in the future. So if someone has a liver cyst, regardless of polycystic liver disease or why you had it, that's water on the bridge. You have it. Now you got to pay attention to make sure that they're not going to act funny in the future. So you ought to really pay attention to them to make sure that they don't have what we call worrisome features or high risk stigmata regarding being something that can turn to cancer in the future, and be careful about what they're going to do. Just to complement what Dr. Roytman said.
Thank you.
So we have a question from Lorraine. Could you talk more about the clinical trials? So it sounds like it's regarding your clinical trials, Dr. Roytman.
Absolutely. So clinical trials study potential medications that may be helpful in the diseases that we currently do not have a treatment or a cure for. So a lot of what I do is working with patients and trials that look at non-alcoholic fatty liver disease. So we usually come up, let's say scientists come up with a promising compound. They say, you know, biologically speaking, it makes sense that this particular compound may help us with a fatty liver, right? So what happens is this compound initially gets studied in the lab, then it gets studied in animal models, and then when it continues to be promising, then it gets into the human trials. And there are phases of the human trials. Phase 1 is done in a small group of patients, and we want to make sure that this medication is safe. This is the number one criteria. Then we move on into the phase 2 trial. In the phase 2 trial, we will again have a small group of patients and make sure that it's safe and effective. Once we've proven that, then we move into the phase 3 trial, larger group of patients. We want to make sure that it continues to be safe and effective in a larger group of patients. The trials that I participate in here at UCSF Fresno, the vast majority of them are phase 2 and phase 3 trials. And I think we are probably getting close to our timeline, right, Summer?
It looks like it's 11 right now. So any questions that, folks continue to have, please place them in the Q&A throughout the rest of the program. We're going to have about 15 minutes at the end of the sessions today to loop back to those questions. So please don't stop putting them in the Q&A. We will get to them. Thank you so much, Dr. Fathi. Dr. Roytman, did you want to say anything before we head to break?
Thank you, Dr. Fathi, for joining us. That was a great presentation. And we do hope that we have some of those biomarkers that you are studying in the near future to help us with an earlier diagnosis.
Thank you for the opportunity. I really enjoyed it. Hope to see you guys next year.
Live.
Live, yes, yes.
All
Bye,
right.
guys.
Thank you so much.
Thank you.
So I'm going to go ahead and send us to break for 15 minutes. We'll be back here at 11:15 to pick up with the second half of the Liver Expo.